are going to talk about the initial prenatal visit. This is hopefully going to be a relatively quick lecture, about 25-30 minutes. And we're really just going to focus on the initial prenatal visit, and subsequent lectures will dig into other components of the initial visit, but I just really want to look at the overview of the initial visit today. So, before we get into the initial visit, though, I want to look at the history of prenatal care. Believe it or not, prenatal care is a relatively speaking, new invention. We didn't even really start doing prenatal care until the early 1900s, when the blood pressure monitor was invented. And public health nurses would go into the homes of women in the 7th or 8th month of pregnancy and take their blood pressure as really a way to avoid eclampsia. And they would really just go one time, take their blood pressure, maybe twice, but that was it. They didn't look at fetal heart tones, they didn't look at weight gain, they didn't do anything else. So it was really just a very limited thing. But it developed over time, and by the 60s, women were coming into provider's office for about 6 to 12 prenatal visits. And then in about 1989, in 1989, and then again in 2005, the U.S. Public Health Service looked at research and really analyzed carefully what we were doing with prenatal care, why we were doing what we were doing in prenatal care, to determine, do we really need to do all of the visits that we do? Do we need to be doing more visits than we do? What really makes good prenatal care? What can we do to make better prenatal care? Because we have these things called the Healthy People 2002, well, there were 2000, there was 2010, now there's 2020, and we're about to launch 2030 goals, because we just can't seem to meet the goals, especially for maternal and infant mortality here in the U.S. And one of the goals is that all women will have access to adequate and good prenatal care. So they really are looking at that. And so when they looked at all of that research, what they determined was that for adequate and good prenatal care, a nulliparous or a first-time mom really needs to have 8 prenatal care visits, and a multiparous mom needs 6, unless they hit that post-dates mark, and then they need 1 more visit. And if that sounds like a lot less, that's because it is. And one of the reasons is that a lot of women don't seek out prenatal care, especially lower income women, because it's actually a barrier for them to get to the office. And so I think some of the thinking is that if we can make it so that women can have good quality care that's done well, even if it is that 8 times or that 6 times, and they know that they can get in and get it done, that maybe that they will access that care rather than feeling like, well, I'm never going to make all of that, so I'm just not going to bother to go at all. They were hoping that that would help make that care more accessible for them. So that is the recommendation by the U.S. Public Health Service. However, very few providers have adopted that abbreviated plan, and most women are getting the schedule that you see here, which is every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, and then weekly those last 4 weeks, and sometimes it's like 5 or 6 weeks until they deliver. And then that usually is about 14 visits, depending on how early they access care. I know in my practice sometimes I'm seeing women as early as 6 and 7 weeks, like the minute they get a positive pregnancy test. So we do see women quite early in their care. So prenatal care, like I said, one of the Healthy People 2030 goals, and it was a 2010 and a 2020 goal, is to increase the number of pregnant women who receive early and adequate prenatal care. Because inadequate prenatal care is associated with poor outcomes and high-risk deliveries. And really, if you can frame prenatal care to really view it as something that is a prevention strategy, we really are seeking to prevent something from happening. So we are preventing eclampsia by identifying preeclampsia or even gestational hypertension. We are preventing preterm delivery by identifying preterm labor. So we're really in the game of prevention in prenatal care. We also are seeking to do a comprehensive health history. We're looking at screening tests, routine assessments. All of that works to contributing to lower women's risks. And a lot of times, women really only seek, in some groups of women, they really only seek health care during times of pregnancy. So it's an opportunity for us to do other types of screenings as well during this time, whether it's depression screening, intimate partner violence, other types of screening as well, sometimes oral health screenings as well. So it really is a time for us to help care for women in other ways as well. So the initial prenatal visit, or the first prenatal visit, is really a time where we are working to establish that trusting relationship. Overall prenatal care, but labor and delivery as well, is a time when women are incredibly vulnerable in all areas of their life, but especially with a provider. We are seeing them at some of their most vulnerable times, emotionally, physically, of course, psychologically, mentally. They are opening themselves socially, psychologically to a whole new phase of life, if you think about motherhood. And that, that can be beautiful and wonderful, but incredibly scary. And we are kind of on the front lines of that transition for them. So it's an honor and a real privilege to be a part of that. And so if we can begin to establish, I don't know that we fully establish it at that first visit, but we're laying the foundation. So I think being very cognizant of that in everything that you do in this first visit will either make or break that appointment. She won't come back if she doesn't feel that she trusts you. So very important that you are high alert to make sure that you are doing everything you can to make her feel safe and that you are someone she can trust. Like I said before, this is a prevention. Prenatal care is prevention, and a lot of what we do to prevent illness and to promote overall wellness is education. So we do a lot of educating in our initial visits, which is usually why, and the benefit of being a advanced nurse practitioner, is that we get to do education and we get more time. So most of our visits will be between, usually we get 30 to 45 minutes. Not all practices have that luxury, but typically we get a little bit more time so we can do that education. And then we're also looking to detect and prevent potential problems. So usually within our health history, in our medical reporting, in our taking the medical history, and then also in our assessment, we will be looking for any potential problems or preventing potential problems. And that will be also in that history, in that physical exam, and any lab tests that we do. And then we'll be taking a comprehensive health history. Obviously, we'll be asking them their reason for seeking care. Most likely they are pretty sure they're pregnant, if not suspicious of being pregnant. We'll want to make sure that we get the date of their last history. We'll talk a little bit more about this, but always making sure that we ask them for the first day of their last period. Many women, I shouldn't say many, but sometimes they'll give us the last day of their menstrual period, so it's important that we always get the first day of their last period, because that is how we date their pregnancy. Also asking them any signs and symptoms of pregnancy that they're experiencing, from breast tenderness, fatigue, nausea, increased urination, maybe nausea and vomiting, whatever it is they may be experiencing. Determining whether or not they themselves have taken a urine home pregnancy test. Maybe they've gone to another clinic and had a blood test. So always making sure that we've asked those questions. We'll also want to do a very comprehensive health history for their medical, surgical, family, and social history, and then a very comprehensive reproductive history, menstrual, sexual, and an OB/GYN history. And this is laid out in your Varney textbook and your Williams textbook very well. Before we go too much farther into the visit, we will want to confirm that they're pregnant. Again, taking a menstrual history will be important, but we'll also want to make sure we have some type of a confirmation through a pregnancy test. There's not or an ultrasound. You can. Some clinics have the capacity to do dating ultrasounds right away at an initial OB visit. There's nothing more heartbreaking to get through all of this and then find out that they're not pregnant at all. It's very emotionally and psychologically draining on the patient. So confirming that, we almost always get urine tests on these patients when they come in for urinalysis and urine culture. So it doesn't take too much to just run a urine pregnancy test to confirm the pregnancy. But whatever clinic you're in may not have the capacity for that just from a financial standpoint. So you'll just want to have some way of confirming their pregnancy. So the menstrual history is important as a way of beginning to start dating the pregnancy. Probably the most primary thing that you need to do beyond that comprehensive health history as you start to develop a plan for this patient is getting that pregnancy dated. That is so important. The dating of the pregnancy is key because it's going to be the basis of everything that we do for the pregnancy. And at the end of the pregnancy, when we're looking at potentially having to maybe do an induction for post dates, or if she ever were to go into preterm labor, so many of our management decisions all are based on that date. So all of these pieces of evidence that you gain, or clues, it's kind of like detective work sometimes, really do come down to the dating of the pregnancy. So the more information that you can build, it's really important that you gather this now, because the farther away she gets from these pieces of information, it's harder for her to recall them. So really important that you're asking good questions. So with the menstrual history, you want to ask things like how old she is. If she's a 16-year-old that's just started bleeding within the last year, she might not have very regular cycles, which would make dating her pregnancy based on her last menstrual period complicated. You want to ask how many days are in her cycle. Most women have cycle lengths between 27 and 31 days, or somewhere in there. So if she has a 45-day cycle or a 20-day cycle, that's going to make dating the pregnancy a little bit more challenging using Nagel's rule, which we'll talk about in a minute. So it's important. And she might not track her cycles, which is a whole other thing as well. So finding out her days in her cycle. Also knowing her flow characteristics, if she typically bleeds 3 days, or does she typically bleed 7 days? And normally she bleeds 7 days, but this last period she only bled for 2. Well, maybe this last period wasn't her actual last normal period. Maybe it was implantation bleeding or bleeding that was associated with the pregnancy in some way. So maybe it was the period before that was her last normal period, and that's the one we want to date the pregnancy with. So important to ask the different flow characteristics. Discomforts related to a pregnancy. Does she have an endometriosis history? Does she have really bad cramping? And this last period, she didn't have cramping. It also could be that that's a sign that this was not a normal period, and so this might not be the actual normal period. Also, did she use contraception? Sometimes people can get pregnant right off of the pill, or have amenorrhea but still ovulate because they just came off of a contraception. So lots of important pieces of information that you need to know based on their menstrual history. Dating a pregnancy by the last menstrual period has its limitations, which are really important to me. I've hit on these a little bit just based on what I was saying. So most cycles are 21 to 30 days, and not all women will ovulate on day 14, which is what we use for Nagel's rule. Not all women keep track of their LMP, and so that makes it sometimes difficult. They may have a history of irregular cycles, and they may not even get a period but yet still ovulate, which can make it really challenging sometimes as well to date their pregnancies based on their periods. Things like medications. I once had a patient who had a really off period. She was off by almost 7 weeks between the ultrasound and her LMP, and the only thing that had she had changed was that she started a new probiotic. So something as simple as that had really messed up her ovulation, I guess it was. Breastfeeding, of course, that can make you not have a period but still be ovulating. Getting sick, this happens. We've all heard this story with someone who is on birth control pills and takes antibiotics that can inactivate the birth control pills and someone can get pregnant. Or just being sick in general can really change your flow and your menstrual cycle in such a way that it even if you track it, you might get pregnant and not and just not have a regular cycle like you normally do. Stress, weight changes can all change your cycle. People who are on shift work, their cycles can get all messed up just because of shift work. So all these things can impact the menstrual cycle, make it very difficult to date a pregnancy. And then the other really big thing, this was actually a study that was mentioned in your Varney book, but spotting in the early part of pregnancy, whether it's from implantation bleeding or just spotting from another reason, can be confused for the last menstrual period because it can be heavy enough that people think it's just a light or a different type of period. And that happens in about 27% of pregnancies. So women can actually think that's their period, but it's not a normal period. So it can just be another confounding influence when we're trying to date a pregnancy by a period. So if we were to date it by a pregnancy, how we do it is, date it by a period, by the last menstrual period, we would do it by something called Nagel's Rule. Now, I'm old school. I'm going to just flat out admit that right here. I love dating it just by doing the math. It's very easy. Nagel's Rule assumes a 28-day cycle and an ovulation on day 14. So that's the downside. But there's apps for this. ACOG has an app you can download on your phone and figure it out really quickly. But do it in your head. Practice doing it in your head. You won't be able to use an app on boards when you take boards. It's really, like I said, super easy. I have it backwards here, but you just add 7 days and subtract 3 months. So if you have someone who has an LMP of 613, you would add 7 days, which would make it 20, and subtract 3 months, which would be March. So the LMP would be 320. So that's easy. Or you can do it backwards. You can subtract 3 months and add 7 days. Whatever floats your boat. But that's the easiest and simple way from a LMP to figure out the due date. And I just want to pause here for a second. So for the longest time, since I was in school till probably in the last 5 or 6 years, we called it an EDC, so an estimated date of confinement. And that was recently, so like I said, in the last 5 or 6 years, changed to EDD, estimated date of delivery. And I think they changed it because confinement can be perceived as an illness or something wrong, or like she's in jail or something. And so, anyways, perceived negatively. But you still might see that once in a while based on if a clinic has like older software, they haven't upgraded it yet, or just someone who's old like me and was trained that way or something. So if you do see someone say EDC, estimated date of confinement, just know that was just how it has been for a while. Or older textbooks might say that. But now I think it's more commonly thought of as estimated date of delivery, as something more like normal, not associated with an illness. So I just wanted to pause just in case any of your preceptors or places where you were working were still using that. I did throw in just a picture of a wheel. I'm sure most of you have seen this. Please don't ever use this to figure out a due date. These things are notoriously inaccurate. Sometimes I think people still will use them once in a while to figure out like a gestational age. They're even pretty inaccurate for that, but like back in the dark ages, we would use them for figuring out gestational ages, never for due dates. But they're still around. I see them floating around once in a while. They're kind of fun, but I just wanted to show you what they look like. So what do we do? So like I said, LMPs, we'll be using, and you'll calculate due dates from the LMPs a lot, especially someone who has a very sure LMP. But the gold standard really is a early first trimester ultrasound. The most accurate due date we can ever get is an ultrasound done before 13 and 6-7 weeks gestation. That is the most accurate and reliable due date we could possibly get. After that, second trimester ultrasounds are not considered as accurate, and by 20 weeks, they're off by greater than 2 weeks. There's a pretty good chart in your Varney textbook. In fact, if the due date is off, if the ultrasound due date and the LMP due date before 13 weeks have a difference between 5 days, you would actually go with the LMP due date. And then by 13 or 14 weeks, if it's a difference within 7 days, you would still go with the LMP due date. And then by 20 weeks, it has to be a difference of 14 days before you would change it. So even even with how close they are, you would still go with the LMP due date if it was a difference of 5 days. But anyway, the most reliable, accurate method for dating a pregnancy in the first trimester is considered an ultrasound if she does not know her due date for sure, and it is the best method otherwise. So just to know that. So that is that's kind of an overview for dating the pregnancy, because that is so important in this first initial visit. So moving on to getting our subjective and our objective data in that initial visit, the first thing we're going to do is prenatal history. And I'm going to just talk a little bit here about presumptive, probable, and positive signs of pregnancy. Your textbooks don't really hit on this a ton, and the only reason I'm pausing is because I know it is a boards question, so I want to make sure that you have this information. So presumptive signs of pregnancy are manifestations. Presumptive signs are manifestations that suggest but are not positive signs of pregnancy. So that would be things like fatigue, breast tenderness, nausea and vomiting, amenorrhea, even fetal movements that the woman feels, uterine enlargement, breast enlargement. But all of those things, if you think about them, could also be explained by something else. Because fetal movements could be gas bubbles, uterine enlargement could be a fibroid, breast enlargement could be just fluid from hormones, the fatigue, the breast tenderness, nausea and vomiting, all could be something else. Amenorrhea could be a hormonal piece or stress or something that's keeping her off. So all those are presumptive. Probable are manifestations that indicate a definite likelihood but aren't for sure. So those would things be like Braxton Hicks contractions, which also could just be cramps, a pregnancy test that's positive, which sounds like, why wouldn't that be for sure? Well, it could be a pituitary tumor that's creating the hormones that might be causing the pregnancy test to be positive. We could see things like abdominal enlargement, which could be psychosomatic, and then that would probably be the other signs. And then positives would be presence of a fetal heartbeat that's heard by other people, fetal movement that someone else sees, and then obviously a fetus that's seen on ultrasound. So those are the signs of pregnancy. So just to kind of test you then, is the following statement true or false? A positive pregnancy test is a positive sign of pregnancy. And then what if it's false, which sign of pregnancy is it? So it's false, and going back, you have your notes right in front of you, but it's a probable sign. So after we've gone through, and I'm going to encourage you to go back to your Jarvis textbook and review the section on obtaining a health history on someone who's pregnant. But then I just want to review the OB history. So one of the things you have to obtain in an OB history is getting the GTPAL. So the first number is the number of times the G, the gravida, the number of pregnancies that she's had, including the current one. The T is the number of term births she's had, so born beginning of her 37th week and on. The P is the number of preterm births she's had between 20 and I guess it'd be 36 weeks. And then A is the number of abortions, so miscarriages and terminations. And then L would be the number of living children that she's had. So an example is a G1P0 would be a woman who's currently pregnant with her very first child. She's never had any kids at all. And then another example would be a G2P0010 will be someone who's currently pregnant now, and then she's had either a miscarriage or a termination at some point in her pregnancy history. And there's lots of other examples in your Barney book as well. But here's another one, so let's test ourselves. So Sarah Jones is pregnant, and she just delivered her first child at 40 weeks, her second at 18 weeks, her third at 38 weeks, and her fourth at 42 weeks. Her LMP was April 1st. So what is her EDD and what is her GTPAL? So why don't you pause and figure that out and start it back up again when you're ready. So her EDD is January 8th, and her GTPL is she's a gravida 5, she's a para 3013, because that second pregnancy never reached 20 weeks, so that would be considered an abortion. So I hope that makes sense. So because she's currently pregnant, and then all those other pregnancies add up to 5, and then she had 3 term, the 1 abortion, and 3 living, so that's the 3013. And then if you add 7 days to April 1st, to April 1st and subtract 3 months, you get January 8th. And then Cynthia Smith is pregnant. Her previous pregnancies resulted in a live birth at 40 weeks, a live birth at 38 weeks, a live birth at 30 weeks. Did I say 38 weeks and 30 weeks? And all of her children are living. Her LMP was 30, or July 3rd, sorry. What is her EDD? And what is her GTPAL? So pause and figure that out. So her EDD is, let's see, I didn't figure this out. 7 is April 10th. And she's a gravida 4. She's a 2103. So she's currently pregnant, and then she's had 3 others, so that makes her a gravida 4. She had 2 full-term pregnancies, 1 preterm pregnancy. She's had no miscarriages or terminations, so that makes her 0 in that column. And all 3 are alive, so that puts her at a 3. So that makes her a 2103. And then July 3rd, if you add 7 days, that makes it 10. And then July minus 3 months would be April. So that's April 10th. And then the next slide, I just gave you a couple more to practice as far as Nagel's rule if you wanted to do that. Because I do believe those are also a couple of board questions. And then just as a quick review, we talked about this earlier, but prenatal visits, usually that initial visit, every 4 weeks until 28 weeks, every 2 weeks until 36 weeks, and then weekly until they give birth. And then the stages of pregnancy, the first trimester is 0 to 12 weeks, second trimester is 13 to 28 weeks, third trimester is 29 to 40 weeks. They're a term pregnancy once they hit 37 weeks. Their early preterm is less than 34 weeks. Late preterm is considered 34 to 37 weeks. There's quite a bit of interesting research about late preterm babies. If anyone is interested in a capstone presentation with late term babies, there's some interesting research going on about that. Just food for thought. And then post-term is considered after 40 weeks. So then after you've done your history, you've dated her pregnancy, you've done all of the subjective gathering you're going to do a physical exam. Now, of course, we do vital signs at every visit, but the physical exam is a full head-to-toe assessment, including a breast and a pelvic exam. You're going to want to examine both internal and external genitalia. You're going to do a bimanual exam. Part of the bimanual exam is to confirm that her uterus is, if you're thinking, because you've dated her pregnancy, so you're going to be thinking, you're going to know how many weeks gestation she is, and so you should be able to also confirm that if you think she's 10 or 12 weeks gestation, you should be able to feel the size of the uterus, and that should also help to confirm that you've got the right dates for her. And then you also want to do some clinical pelvimetry and try and determine the shape of her pelvis, which will, at least you're always going to give her a trial of labor, but it will at least give you some thoughts about what labor is going to be like for her, especially if she's a prime. And then we always do lab tests at the initial OB visit. And it helps to think of the lab testing that we do as 4 types of lab tests. We do routine tests, blood tests to screen for infections or immunity to infections. We'll go through those in just a minute. And we also do lab tests to detect certain conditions or infections for at-risk women. And then we talked about this in a previous lecture, but we do fetal screening tests for certain genetic conditions. And we can also do carrier screening tests for either biological parents. Now, the fetal screening test you may or may not do at the initial OB visit, depending on how many weeks gestation she is, because they have to be done at specific times. So they may not be done at this visit. And the carrier screening test can be done at any time during the pregnancy, because she's already pregnant. Ideally, those carrier tests are done prior to pregnancy, but they can be done at any time. So this is somewhat the same as how it's laid out in Barney, but these are the routine lab tests done that in pregnancy. So there's blood tests. We do a CBC to mainly look at the white blood cell and the hemoglobin and hematocrit. We also do blood typing, Rh and antibody screen. We look at hepatitis B, HIV, VDRL, and RPR. And then we also want to check immunity to rubella and chickenpox, varicella. We do urine tests, a UA and a urine culture, if need be. And then pap smears if she is over the age of 21 or if it's been within the screening period, if she needs it done. And each clinic is a little bit different. Some clinics just routinely screen everyone for chlamydia and gonorrhea. Some people only screen if they're at risk, so you will do those based on the policy of the clinic that you're at. We did talk about fetal and carrier screening at a previous lecture, so we won't cover that here. And then usually initial OB visits do a lot of teaching because we are a prevention-based prenatal care. So most clinics will have either handouts or a booklet or something that they give that will cover a lot of this. Sometimes the nurses do it, oftentimes it is the nurse midwives that are doing it. But if need be, we go through nausea and vomiting relief measures. We usually talk about listeriosis prevention or avoidance, which is, there's quite a bit out there on that, so I will let you read that on their own, as well as toxoplasmosis. We talk about exercise. We do talk about nutrition, but that is a whole week's content in this course, so I'm not going to cover that here. We talk about medication safety. There's a lot of over-the-counter medications that are not safe to take in pregnancy, so patients do need to be counseled to talk to either the pharmacist or their provider before taking any over-the-counter medications. We also talk about avoiding all alcohol, drugs, while being pregnant. I am finding in my own practice more and more that women are using marijuana for nausea relief. They're being told that that's a really great medication to take, which for cancer patients it is. It's not such a great drug for pregnant women. So asking specifically if they're using marijuana is really important, especially for nausea, and then talking about that. Obviously, smoking cessation is something we want to cover and talk about as well. We also talk about immunization recommendations for the pregnancy. It's also important to review the practice, who the providers are, how the protocols work in the practice, like who's going to deliver them. It might be a little bit different in each practice, how that works, so just letting them know how that works and how your practice is set up, and then who to call and when to call, and then reviewing any danger signs for the trimester that they're in, when they should call. All those parts and pieces I'll be covering in later lectures, but going through that with the patient. If you have uncovered any medical issues during their history taking or during the exam, you'll want to develop a comprehensive plan with them for follow-up, whether you need to refer them to a collaborating MD or maybe to like an endocrinologist or a dietitian, or maybe to get an ultrasound. We already covered talking about cessation of smoking. You also want to, again, go through like when their next visit's going to be, how they should contact any providers. Also, what hospital are they going to, and what's the best way for them to go to the hospital? If they do go to the hospital, do they go up to the maternity care center, or do they go to the ER, and when does that switch happen? Each practice also is a little bit differently. You might have a designated person that works with them for insurance, so they know like deductibles and out-of-pocket expenses, or maybe it's the midwives that take care of that. Especially when it comes to like the fetal carrier screenings, not all insurances cover that, so they'll want to know what their options are before they agree to those expenses. And then last, you'll want to plan on screening your patients for depression and intimate partner violence at least twice during the pregnancy, and make sure that you document that you've done it and the tool that you used. Like I said, they are at risk. They are at risk for depression because of just physiologic changes, but they are at high risk for intimate partner violence because of the vulnerability that they are experiencing. So it's really important that we are caring for them during this very most vulnerable time. So that is all on the initial OB visit. I have just a little slide here that I love on just some bizarre pregnancy facts that I thought was kind of fun that I will leave you with. And I just hope that you all have a great day. Please let me know if you have any questions. Post any questions you have in the general forum. Otherwise, I will look forward to talking to you all later. Take care.